My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program of Orlando Health UF Health Cancer Center in Orlando, Florida. So nipple sparing mastectomy is a procedure that removes the breast while leaving intact all the skin of the breast and also the nipple areola complex. The history of mastectomy went from the radical mastectomy that removed the breast, the skin, and the underlying muscle, actually back in the 70s, to then the modified radical mastectomy that preserved the muscle but removed the skin of the breast and the breast tissue, to the what we call the skin-sparing mastectomy that removes the breast with some skin around the nipple, like an elliptical incision or a vertical incision, but the nipple then is removed. And finally, the nipple-sparing mastectomy, where all the skin of the breast envelope is preserved, and then we shell out the breast but leave all the skin. And of course, how we got to the point is that, again, breast cancer today is not the same as breast cancer in the 70s, where with larger masses. Now with mammography, we detect smaller lesions. And what we found was that when you do mastectomy today, nowadays, the nipple is not involved in the majority of the patients. 90 to 95% the nipple has no involvement. So the question became, why do we need to remove the nipple? What is the reason for that? And of course, to get away from that and not remove the nipple, you have to do a very careful intraoperative or postoperative evaluation of the nipple areola complex to make sure there's no nipple involvement histologically, even if you don't think that by MRI, mammogram, and ultrasound. And of course, there have been now several trials that have demonstrated the feasibility of nipple-sparing mastectomy and its safety. However, long-term follow-up is still required to make sure that recurrences don't occur later on. Obviously, the main advantages of nipple-sparing mastectomy is increased cosmesis and preservation also of some nipple sensation, although this is variable. Sometimes the nipple can be saved, but the sensation and the stimulation of the nipple cannot happen. And of course, the potential concerns of nipple-sparing mastectomy is, first of all, that there could be nipple necrosis, nipple loss, because the blood supply of a nipple is mostly taken from the inside the breast and not from the surrounding skin. And of course, is long-term oncologic safety. So there are criteria of who is the best candidate for nipple-sparing mastectomy. Usually, tumor size less than 3 centimeters. Location of the tumor at least 2 centimeters from the nipple. And of course, preoperative MRI showing no extension of enhancement towards the nipple is an important component. Obviously, absence of multicentricity in the breast, absence of segmental malignant calcifications that extend to the nipple or nipple enhancement by MRI. And of course, clinically negative nodes is a good thing to have as well. And also negative intraoperative or postoperative biopsy of the nipple areola complex. Some people do intraoperative frozen section. Some people just mark the nipple area and then do permanent assessment. And if, of course, that comes back, you can go back and remove the nipple. And you can do nipple-sparing mastectomy through a variety of incisions. The most popular incision is via the inframammary fold. So the patient has no scars in the breast once she gets reconstructed.